Welcome to the second section of target elimination. What is target elimination? Target elimination is an hypothetical randomized trial that we would like to conduct to answer a causal question, essentially to learn what works and what harms. The causal analysis of observational data can be viewed as an attempt to emulate some target trial. If we cannot translate our causal question into a target trial, then we need to revisit the question, which may be not well defined. This approach of target elimination is not new. Previously attempted, explained by Don Cochrane, where they tried to apply similar approaches to explain time-fixed treatment and a single eligibility point. It was further refined by Robbins and Hernan to analyze explicit generalization to time-varying treatments and multiple eligibility points. Target trial involves a two-step process where essentially we start by asking a causal question, thereby specifying the protocol for a target trial, and then trying to answer the causal question either by conducting a target trial, which is an RCT, or use an observational data to emulate a target trial explicitly. Being explicit about the whole process is the key here. And to do this, we apply the appropriate causal inference analytics as and when required. So, it's a two-step algorithm for causal inference proposed by Miguel Hernan, where step 1 involves asking a causal question and step 2 is answering the causal question, emulating a target trial. Then we have a choice, either to conduct the target trial, which is an RCT, or analyze the target trial using found data, which is derived from electronic medical records or administrative or claims data or any nationwide registry databases or a disease-specific database. Remember that we can never hope to emulate a tightly monitored or placebo-controlled RCT using observational data. We just try to emulate the pragmatic trial, which is equivalent to an RCT. Let us see this example. This is an age-old question of trying to find relationship between postmenopausal hormone therapy and the risk of heart disease among postmenopausal women. One of the well-known observational epidemiological study derived from the NPTEL study, which was conducted in 2006, revealed that more than 30% lower risk in current users of postmenopausal hormone therapy when compared with women who have never used postmenopausal hormone therapy, with a hazard ratio of 0.68. The NPTEL study is a large observational database, which is purely case of occupational registry, which revealed a lower risk for heart disease among postmenopausal women who were using postmenopausal hormone therapy. On the contrary, a large randomized trial revealed a more than 24% higher risk among women who initiated postmenopausal hormone therapy. We need to find why the discrepancy occurred in the first place. Let us look at the studies involved. The Women's Heart Initiative, which is the RCT in question, is a double-blinded, placebo-controlled, large sample size of more than 16,000 US women aged 50 to 79. The women were randomly assigned to estrogen plus progestin therapy or a placebo, and all the women were followed approximately every year for a maximum of 8 years until an outcome of not just cardiovascular disease. There were other outcomes which were measured, like breast cancer and many other outcomes. This data, the results revealed that the hazard ratio for coronary heart disease showed that on follow-up in the initial years showed an increased risk of 50%. Thereby, if you go progressively after 2 years and up to 5 years, risk showed an increase of around 30%. If you go further, after 5 years, the hazard ratio dropped significantly and showed a protective effect of roughly around 30%, thereby implying that the more susceptibles are available in the population under study, the hazard ratio tend to skew. This hazard ratio can be fully explained by selection bias, even if no woman benefits from hormone therapy. Here, did the observational study get it wrong? No. Insufficient adjustment for lifestyle and socioeconomic factors can be a possible explanation for this. On the contrary, The alternative theory is the observational studies were not emulating a target trial. The question which was asked by the observational study was not akin to a causal question. For example, the question asked here was the RCT compared women who initiated therapy with women who did not. This is not exactly what the observation study asked. The design involved women randomly assigned to initiation of hormone therapy or placebo. Almost all women assigned to initiation received at least a single dose, that is, who were classified as initiators, compared to the risk between initiators who were incident users and non-initiators of hormonal therapy. This trial informs decision about therapy initiation when compared to observational study where the women were asked about therapy use and they were classified as current, past and never users. Thereby, we were comparing the risk between current users who are prevalent users and never users of hormone therapy. Now, both are essentially two different questions. The observation study measured the incidence of coronary heart disease among two different populations of prevalent users of postmenopausal hormone therapy, whereas the RCT measured between the initiators and the non-initiators. Now, what if we reanalyze the observational data using our causal inference algorithm, whereby we specify the protocol of a target trial of a hormone therapy and coronary heart disease, and we try to emulate it. This was published by Hernan in two different instances, thereby explicitly stating the target trial that we wanted to emulate. The first step in the target emulation is to ask the causal question and then try to emulate it. While emulating the target trial, we need to first write the intended target trial in terms of the protocol, whereby we explicitly state the eligibility criteria, the treatment strategies, assignment procedures, follow-up period, defined outcomes, the stated causal contrast for analysis, and the analysis plan. These are essentially the same components which are part of the intended target trial. The same can be applied to analyzing any found data. Here, we explicitly state this protocol where we try to analyze the causal angle between hormonal therapy and coronary heart disease. The treatment strategies assigned being estrogen plus progesterone therapy at baseline and on follow-up compared to people who are refrained from taking hormonal therapy during the follow-up. The outcomes being coronary heart disease diagnosed by a cardiologist. The causal contrast is established by analyzing the data using intention to treat effect as well as per protocol effect. The emulation is achieved by using an eligibility criteria where the analysis is restricted to women who met eligibility criteria of the target trial. The treatment strategies assigned are initiation and continued use of hormonal therapy even during the follow-up, and the outcome is a diagnosis of coronary heart disease during the follow-up. One of the most important steps which differentiates the target trial from an RCT is random assignment, and that is achieved using adjustment for confounding. If insufficient data on confounders, then emulation of random assignment fails, thereby introducing confounding bias. We can use any number of techniques to adjust for confounding, either by matching or stratification or regression or inverse probability weighting. No matter what technique we follow during analysis for adjusting for confounding, it doesn't matter as long as we ask a causal question and we analyze based on a target trial emulation method. When we reanalyzed the data set from the observational narcissistic study, the overall effect estimate or the hazard ratio turned out to be 1.05, which is not much different from 1.23, which was derived from the RCT. On further evaluation of follow-up data from 0 to 2 years, the hazard ratio was not much different, where the observational data revealed hazard ratio of 1.43 and the RCT revealed hazard ratio of 1.51. So, on further analysis of follow-up data from 0 to 2 years revealed that the hazard ratio observed using the narcissistic study was 1.43 versus 1.51 in the RCT. Thereby, the effect estimate was not much different between the two methods. The target trial that we try to emulate in essential should be a pragmatic trial. The observational data cannot be used to emulate a placebo-controlled trial where at most a trial with a usual care group. Treatment strategies that do not exist in the real world cannot be compared. and tight monitoring that doesn't happen in the real world as enforced in a RCT. So, between the ideal trial we would really like to conduct and the trial that we may reasonably emulate using an available data. The two-step algorithm is typically an iterative process where specifying the protocol of the target trial requires detailed knowledge of the database, and the target trial approach allows you to systematically articulate the trade-offs, such as regarding the eligibility criteria, treatment strategies, and stated outcomes. The emulation of a target trial is what we do when we cannot conduct a trial. Reasonable people will always prefer a randomized trial, but often there is no alternative to observation studies. So we better keep improving them because people will keep using observational data to guide their decisions. And we have identified some simple ways of improving observational analysis to learn what works and what harms. Thank you.